Yet another potential etiology for primary amenorrhea that's usually on a secondary amenorrhea list is polycystic ovary syndrome. Polycystic ovary syndrome, it means a lot of different things to different people. And back in 2003, there was a conference in Rotterdam that's quite famous, where they had experts from around the world come up with criteria for just what polycystic ovary syndrome is. So they came up with criterion number 1 being oligo or anovulation. Number 2 is hyperandrogenism. That's clinical signs of hyperandrogenism. And number 3 was polycystic ovaries on ultrasound. And after excluding other causes like congenital adrenal hyperplasia, androgen secreting tumors, and Cushing syndrome, if women have 2 out of these 3 criteria, they actually have polycystic ovary syndrome. So you can see there's no mention of obesity. Here in the United States, we've always thought of traditional Stein-Leventhal syndrome, which was obesity, amenorrhea, and hirsutism. But based on these newer international criteria, you don't need the obesity factor. But these women can present during their teen years with primary amenorrhea, and can be somewhat difficult to treat. In most cases, you would treat them with a progesterone or progestin challenge in an attempt to get them to menstruate. So those are the basic causes of primary amenorrhea. If you just keep those in mind, you will have more than 95 or 99% of these cases solved. The key is in evaluating these people to go through a stepwise progression. First thing you're going to do is measure FSH and estradiol. That'll tell you if they are in a normal at a normal level of reproductive function, or if the FSH is high, whether they have gonadal failure. You're also going to look at a level of TSH, thyroid stimulating hormone, and prolactin. As I mentioned, the hyperprolactinemia is a common cause. I didn't really go into detail about thyroid disease, but women with either profound hypo or hyperthyroidism can also have problems with primary amenorrhea. The next thing to do then would be to see on exam, do they or do they not have secondary sexual characteristics. And then do they have a vagina with a visible cervix? Also, what about their breast development? These are all clues as to what your diagnosis might be. You should further consider looking at signs of hyperandrogenism. Do they have hirsutism? If you are trying to decide whether someone with a blind-ending vagina has MRKH or androgen insensitivity, it might be worthwhile looking at its testosterone level. If you think that they have androgen insensitivity, potentially, you may want to get a karyotype. And again, you would not take out their gonads until after puberty. I think this is a relatively brief summary of things to consider when you're facing a patient with primary amenorrhea. The key is going ahead in a stepwise progression and offering reassurance, since in many of these cases the amenorrhea can be reversed.